So, good afternoon, everyone, and welcome to the last sessions of the day. This session is on strategies and intervention to improve qualities of cause of death. My name is Virapon Potisiri, and I'm a statistician here at SCAP. I will moderating this session together with my colleague Joanne Thomas. So our session focuses on the critical issue that we are facing now, improving the qualities of cause of death, particularly addressing ill-defined causes and misclassifications. And these challenges directly affect the reliability of mortality statistics and the policies and decisions that has been made based on them. So today we have three excellent presentations from South Africa, Ghana, and the Maldives, and each paper offering practical insight from different data system and country contexts. Before we begin, just a few quick housekeeping notes. So each speaker will have around 8 to 10 minutes for their presentations, and we'll give time reminder at 5, 3, and 1 minute remaining. I kindly ask the audience to keep your questions until the Q&A at the end. So you can put them in the chat in case that you worry that you're going to forget it. And I hope everyone can stay with us through the end of the sessions for what I'm sure that will be rich discussions. Without further ado, our first presentations, I would like to invite Mr. William from ECA, who will be delivering the presentations on behalf of Ms. Senele Mawetni from Statistics South Africa. The paper titles Profiling and Ill-Defined Codes to Improve the Accuracy of Cause-Specific Mortality Data in South Africa. Unfortunately, Ms. Sanale unable to make it to join in person. She is a statistician at Statistics South Africa with expertise in data management and quality assurance. She holds degree in epidemiology and biostatistics, as well as demography and population studies from University of the Witwatersrand. Um, for Mr. Williams, everyone know him. So he's the Chief of Statistics, Productions, Methods, and Research, Information System at the Economic Commissions of Africa. Mr. Williams, the floor is yours.
Okay, thank you so much. You have combined my two titles, the official one at the UN and the new one, but it's okay.
Okay, I'm so sorry.
So thank you so much. As introduced, I'm presenting this paper on behalf of Zanele, and I think she should be online. So if I will defer all the questions to her. Because she's the author of the paper and she knows the methodology better than me. It's a subject which I understand. So I think let me give her acknowledgement of the people who she worked with. Her supervisor Pamela, then her mentor Mosidi, and the institution where she's working at the moment, Stats South Africa, for providing the data and the institutional support to let her embark on the CAT program. Then obviously me for presenting it on her behalf. So I think we start from the basis that one of the vital events which we sort of never look at in greater detail, except like in the previous session, there are now people looking at cause of death. It's a very important vital event. And it's a bit different from the way the other vital events are actually recorded. In most countries, it comes as a second part to a death certificate. which is very understandable in the sense that you have to ascertain the fact of the death first before you go into the characteristics of a death. So you find the information on cause of death is usually either, an attachment or an annex of actually the fact of the death. So what do we get from cause of death data? It gives us the mortality profile or morbidity profile of a population. And this is very important for public health interventions. I mean, we are just from the COVID, pandemic, and we saw how it was necessary to actually capture COVID-related mortality, or those who worked during the HIV/AIDS era. You actually know that it was quite important to see which AIDS-related deaths were actually these in relation to the other. So it would work if we have a very good profile on the cause of death. But as identified by Zanele, the issue of ill-defined, causes are actually high in most populations, especially in South Africa. And these are identified using ICD code 10, ICD-10 codes R00 and R99. And in South Africa, this amount is actually increasing. So it increased from 12.4% in 2004 to 18.6% in 2021. Actually, that shows the problem is actually magnifying. It's actually increasing. And obviously, in technical languages, these are called the garbage codes. So what do we do with garbage codes? What Zanele is arguing here is we cannot throw away this data. There is something which we can actually do and adequately present the profile of cause of death while incorporating these ill-defined causes of death. So the acronym for that is actually ill-defined cause of death, IDCD. It sort of confuses with ICD, but it's an acronym you'll get used to, those who will be interested in this subject. Next slide. So what methodology did she employ? So she looked at all the non-natural causes of death which were excluded, leaving, and you can imagine, 465,657. And all records with indefined underlying causes of death, these were actually 114. So if you look at the proportion, it's almost like 1 in 4 of the deaths were actually ill-defined. So she proposes to use a method which tested and tried, I think, in Brazil by a scientist called Franca. And this involves calculation, the redistribution of coefficients which can actually be used. And I will slightly get into that a bit to explain why coefficients are more effective than just using a proportional, reallocation of the debts. So the coefficients are actually based on the methods looking at actually how the debts are actually distributed, the ill-defined, causes. Then you make an assumption that the profile of the causes found from those which are investigated or coded is almost the same as those which are not coded. So you actually calculate a coefficient which you use to redistribute those. One of the things I should caution, still there will be some which will remain garbage because they can actually not be redistributed. Um, and the method doesn't redistribute all the deaths because definitely it makes sense. Ill-defined, there's also ill-defined of an ill-defined. So those become ill-defined forever. Then you apply a correction process. So next slide. So just the one back. So you can actually see, we know medical certification is actually done by medical doctors, but look at the number which are actually ill-defined and coming from medical doctors. They are the least persons you would expect to do that. Then interview of the family, these are almost like verbal autopsies. Then there are the unknown medical practitioners and so forth. So this just gives you where these ill-defined causes of death are coming from. So let's just go to the next, which is the actual result. So the most important part is using this method, you can correct for about 28%. So this 28%, as you can see, it's a minus, which reduces what is originally 114,953 to 82,766. And so this 28% has to be redistributed. When you redistribute it, you can actually see a large proportion of it goes to respiratory diseases. And it makes a lot of sense because what we are actually saying is most of the problems are actually coming from assigning causes of death on respiratory disease. So that 28%, a large chunk of it goes there, then possibly behavioral disorders. And this is a very, very important finding for South Africa because they are not accounting for the respiratory diseases. Next slide. So from that application of the method, firstly, from the 18% of registered death, which didn't have ill-defined causes, we can actually work out and reduce that by 28%. So what it actually means also from that table is 28% of these causes predominantly from the circulatory system. This aligns with actual global evidence showing that ill-defined deaths are often concealed conditions such as hypertension, asthmatic heart disease, stroke, chronic respiratory illness, and underreported infections. Another major finding also coming from just an application of a very simple method which you can actually apply. I know most of the places ill-defined causes of death are quite rampant. The results suggest a burden of cardiovascular diseases in South Africa. So one policy related finding. Next slide. So we recommend that high prevalence of ill-defined causes of death certified by medical practitioners indicate a need for continuous training. So if we are saying almost 18, 19%, so there should be something which will be done, which needs to be done to the medical practitioners. Then strengthening health information systems through investment in electronic death registration, which is what we are pushing for countries now, that they should actually digitalize these systems. The redistribution method should be institutionalized in Statistics South Africa. As we can see, it is a very useful method. So she proposes to have the next step, which is conduct further analysis by applying the method to stratify it by age and sex, actually, which is also a requirement of the method. It becomes finer if it is actually done, especially by age. Then lastly, explore the use of machine learning to actually quicken and make the system more efficient. We are just hoping that when she has derived the uh, machine learning code, we can use it in other countries, because this is what AI is all about. Once you generate codes, they can be applied where things are standard. We know death certificates are standard, cause of death, forms are standard. So we hope that this will be applied also. Thank you.
Thank you, William. So now I see, yeah, I see question in your eyes, but please keep it to the end of the Q&A. So let's just move to our second presentation. So I'm happy to introduce Mr. Basil Tungbani from Ghana Statistical Service, who will present on accuracy and of cause of death classification in Ghana, evidence from the district health management system. Mr. Basil is a statistician and demographer specialized in civil registrations and vital statistics. His work focuses on improving the accuracy and use of vital data, including birth, death, and cause of death statistics, to inform public policies and health interventions. He has contributed to several studies on mortality data qualities and the integrations of vital statistics into national system. Mr. Basil, over to you, please.
Okay. Thank you very much for the introduction, and good afternoon, everyone. Next slide, please. Okay. So I'll first want to begin by acknowledging the Economic Commission of Africa, UNECA, and ESCAP as well, and the Ghana Health Service, and then my home institution, the Ghana Statistical Service, and particularly to my mentor, Dr. Mosidi. Next slide, please. All right, thank you. Permit me to use just a minute or two to really put this study in context. So in 2017, the Ghana Statistical Service, which is the institution mandated for monitoring the Sustainable Development Goals, conducted an assessment. And the purpose of this assessment was for Ghana Statistical Service to see how much of data that we need to be able to measure the Sustainable Development Goals. And as you rightly would know, just as many national statistical organizations, we mainly rely on surveys and then our censuses, but that isn't enough. We found out that 57% of the data that we require in measuring these SDGs are actually emanating from administrative sources. But then in our case, and I'm sure it's the case in most countries, administrative data sources are often not utilized because these are more or less like a routine work for persons who are often engaged in such services. So the purpose of this study, which is actually looking at the accuracy of cause of death, is first to put the context right that administrative data can also make the difference. There is a lot of statistical output that we can get from administrative data sources. And once we are able to ensure the accuracy of such data, then we can actually use it to inform policy. And secondly, the study is also seeking to establish the fact that there are some errors. And this came up in the South African presentation as well. So we are also seeing the same in our context. So the essence of it is to also bring out these errors so that going forward, recommendations will be made to ensure that medical officers who are in charge of producing this data take in the right measures to ensure that the data comes out in quality. And once it's quality, we can actually use it for more statistical information that will feed into the national agenda. Next slide, please. So let's take a look at the Ghana mortality data landscape. So in the case of Ghana, just like other African countries, our data systems are fragmented. We have different institutions collecting almost the same data, but then the challenge often is with the fact that these different institutions uses different structures in terms of like the questionnaire, in terms of their methodology of collecting the data, even with the concepts and the metadata involved in collecting this data sometimes vary. And in other cases, they are also the same. So in the case of this presentation, I am particularly limiting it to the district health information management systems data, which is actually being collected by the Ghana Health Service. And this is a data that is based on facility deaths only, and it actually cuts across the entire country. Next slide, please. So as I did mention earlier, the two objectives first is to first determine the leading causes of death by sex, and then the second will be to assess the data quality issues in this cause of death. Next slide, please. Okay, so for the research methodology, just as I did indicate first, I'm using the District Health Information Management Systems 2. It's 2 here because the version was recently, it was updated to the version 2. Earlier it was version 1. So this data was gotten with permission from the Ghana Health Service, and the data was delivered in the form of Excel. And I used the ANACODE 3 tool to analyze this data. Now, ANACODE 3 tool was a tool that was developed by the WHO to be used in assessing mortality statistics. So I wanted to see how this would turn out. Is it going to be different from the case of other traditional data sources that we have, or what is it going to be like? Next slide, please. So let's just to take you through the process I went through in coming up with this analysis. So the first stage was to get the data in the form of Excel. And then the next step was to ensure that I did a rigorous data cleaning, because in most cases, just as we know with administrative data systems, they usually come in an incomplete form. So either the age is missing, either the particular cause of death is missing, or the sex of the disease is missing. So I had to ensure that all this data was actually complete in order to be able to use the ANACODE 3 tool. So in instances where some ages were not provided, the estimated ages were used. But in instances where most of the data was missing, I couldn't really use such data. So I had to take it out, further reducing the sample size, which of course is a limitation, but the ultimate goal is to ensure that we can actually use this data if the information are rightly provided. So after the data cleaning processes, the data was then inputted into this ANACODE 3 tool, and the summary statistics were generated. Next slide, please. There's actually a lot of analysis that I did from this data, but for the purpose of time, I decided to focus my discussion on the sex distribution of the top leading cause of death. So the top 10 leading cause of death, comparing between males and females. And just to establish the caveat that this data is actually based on the top 10. So the percentages are computed from the top 10 and not the entire causes of data for each sex. But once we look at this chart, we can see that for cause of death, as I was so happy to hear the case of South Africa, because it's also respiratory infections that we are seeing in our case. Even though, as I did indicate earlier, that there are a lot of incompleteness in this data, but at least it's still depicting the expected results that we would expect to see. And aside that, one particular interesting thing that particularly struck me was the fact that if you look at the top 10 leading causes of death for females, we see the last, there's HIV there, which is actually missing in the case of males. And then again, for the top 10 leading cause of death, whereas it was lower respiratory infections for males, we see that for females, it was cerebrovascular disease. So this shows that there are actually some differences when it comes to the cause of death comparing between males and females. Next slide, please. Yes, so as a statistician and demographer at GSS, I think I'm particularly more interested in this part of it. Why? Because this second portion of the work is seeking to assess the quality concerns. What are the quality issues? I'm sure from the data we saw previously, we'll begin thinking whether we would want to is it possible? I'm sure maybe some of the questions that may be coming could be that, is it possible to use this data analysis to make informed decisions? And people will be willing to know whether the findings are actually very accurate enough to be used for planning. But the issue actually is we need to first establish that, yes, we can use this data, but we can only use the data when we have good data. So it's more or less garbage in, garbage out. So once we are able to also ensure that the data is put in its appropriate form, then we can be sure of the results that are coming up. So from the quality assessment that was done on this data, we found out that 30% of the data was actually misclassified. So most of the codes that were inscribed, inputted as part of this District Health Information Management Systems data were actually misclassified. And we only had about 70% of the codes accurately classified. Next slide, please. So moving into the discussions, actually data quality issues is of concern. And if we want to really ensure that we are able to use data in informing effective health decisions, then we need to ensure that the data is of quality. So that was one thing that came up. Secondly, just as the case of the previous Ghanaian speaker, in the case of this DIMS also, we see that non-communicable diseases also accounted for the higher proportion. That's like 57.4%. And then followed, next slide, please, followed by the communicable diseases, which was 36.6%. And then again, I did mention earlier, we have gender disparities in the causes of death. And then again, there are increases in maternal health cases as well as neonatal deaths. But this is expected also because in the case of institutional data, we always expect that most children should be born in the hospital. So once they also die in the hospital, it's very possible that such data can easily be captured compared to those that may be born outside of these health facilities. So in the paper is actually being published, so hopefully from the agenda, you can have a link to the paper. If we look at it, the first chart that we did was to look at the trend of the disease mortality across the ages, and then it's so high for the neonatal less than 1 year old. And then again, we also saw that there were more females dying across the ages, except for the older ages. But then the expectation is that by then, more males would have died. So that's why maybe it's possible. So maybe that's, I'm not showing here by saying there. I just wanted to mention it. Next slide, please. So what are the recommendations? The recommendations are that we need to actually improve our digital validation rules within the DIMS. How do we do this? We can do this by institutionalizing regular data quality audits so that when the data hits the system, there is a specialized health practitioner who is experienced in this cause of death analysis issues to be able to certify such a code before this code is being accepted. And then we also need to strengthen our supervisory mechanisms, ensure that these health professionals are actually doing the right thing. Why am I emphasizing on this? It's important because as per their mandate, they are not to produce statistics. So it is just to collect the data. So they don't really pay much attention to the use of the data, but it's more on collecting the data. So secondly, we also need to actually integrate our mortality review processes. Documentation is key. So if the cause of death is not properly documented, then it's also possible that in case of entry and other related issues, such a death can be misclassified. Thirdly, we also need to actually further ensure the integration, which I very much like. And just to also reiterate again, for yesterday, the Ghana's presentation was on BDR, from BDR, the Birth and Death Registry. And this is an institution that's actually collecting data on birth and deaths. We also have the Ghana Health Service. Once the person dies in the hospital, the data is captured into the DIMS. And we also have the Navango Health surveillance systems also collecting data on mortality. So these are all different institutions. So if we are able to really integrate these systems, then we can have a more comprehensive CRVS system that we can use to inform effective policy decision making. Last slide, please. So on conclusion, cause of death misclassification still remain actually a measurable challenge, and we believe that if the targeted interventions are taken into consideration and all government institutions, stakeholders are brought onto the table, the discussions can be taken further to enhance the quality of this data that we use and also inform the effective decision making that we want. Thank you very much for listening.
So much for very informative presentations. Let's move to our final speakers, Ms. Fatima Riaza from the Maldives Bureau of Statistics, presenting on prevalence and determinants of ill-defined causes of death in the Maldives, and analysis of decades of mortality data. Riaza heads the Population and Social Statistics divisions at the Maldives Bureau of Statistics. She plays a key role in conducting the population census, strengthening social statistics, and improving vital statistics in the country. She also actively engages in national coordination mechanisms and serves as the CRVS focal point for SCAP. Riaza, over to you, please.
Thank you, Tom, for the nice introduction. So like other speakers also, let me start by thanking my co-authors who have contributed a lot to improve my paper, Ms. Sheena and Ms. Sofura. Of course, I would like to extend my deepest thanks and gratitude to Ministry of Health for sharing the data set in a timely manner, the UNESCAPE team, the CART team, Bloomberg Philanthropies Data for Health, and of course the administrative support that was provided by the CART team as well. So why look at ill-defined cause of death when others are looking at the main cause of death in a population? One of the main reasons why I focused on this topic was we have a high completeness of death registration in the country, but we do face the challenges of having quality cause of death coding being done in the country. And as a result, we are unable to identify the true burden of non-communicable diseases in the country that is mainly due to the increase in number of ill-defined causes of death. And as Ministry of Health point highlighted or quoted in their health statistics, when the deaths are of, when they look at the quality of the cause of death, 50% of the deaths are not usable for them. And this makes cause of death of little use for health policy planning. In the latest vital statistics report that we have published in the country, we had to remove the ill-defined cause of death to actually analyze, do a good analysis of cause of death in the country. And coming back to the literature on the ill-defined cause of death, we have very limited researches that is being done in the country. One study which was done focused on the garbage code, which is going beyond more and including more causes of ill-defined causes of death. And at a time when we are facing an aging population, accurate cause of death are critical to forecast future healthcare demand. And for us, being a small island nation, the geographic distribution of ill-defined causes of death becomes important, and the main reason why I focus on this topic as well. Moving on to the research method, the primary data that I have used for this study comes from the vital registration system in the country, and the data covers the period of 2011 to 2021. Similar to my previous speaker, I have used the NACOD 3 tool to classify ill-defined cause of death, which goes beyond the ill-defined cause of death included in the chapter 17, but also includes unspecified and vague causes included in other chapters in the ICD 1011. For my analysis, I did a very simple analysis, which included descriptive statistics, exploring the prevalence of ill-defined cause of death across key variables such as year of death, sex, age group, and looking into the various geographic regions in the country. In addition to that, I also conducted logistic regression to identify the key determinants for the use of ill-defined cause of death in the country. Now, coming on to the looking at the results, firstly, when we look at the prevalence of ill-defined cause of death, over the 10-year or 11-year period, 36.4% of all the deaths in the country was assigned an ill-defined cause of death. And looking at the two categories of ill-defined cause of death that is used in the NACOD 3, we have the category 2 codes are more predominant in the country than category 1. Looking at the sex differences in the ill-defined cause of death, women consistently had a higher proportion of deaths coded with ill-defined causes compared to men in Maldives. Next, moving on with the results and looking at the regional distribution of ill-defined causes of death, what we saw in the result is the central and the southern region had the highest initial prevalence of ill-defined causes, but it improved over time, and north region and south region in the country showed an increase in ill-defined cause of death over time. And the most common ill-defined cause of death used in the country was I461, which is cardiac arrest, and R99, which is other ill-defined and unspecified cause. And the third most common code was the I10, which is essential primary hypertension. So looking at the findings coming out from the logistic regression that I did, age was one of the strongest determinants when the individuals aged between 18 to 35 were 4 times more likely to be assigned an ill-defined cause of death, followed by those in the age group age 65 to 65 years and above. Females showed a higher odds of receiving an ill-defined cause of death than men. And when looking at the regional distribution, the place of death by geographic region, what we saw is central region had a higher odds of receiving an ill-defined cause of death. This sort of indicated there is a persistent regional disparity in the country, and this region being located within in the region where the capital city is also located in the country. Now, moving on to the discussion, this was the first study. I would like to highlight that this was the first comprehensive analysis conducted in the country looking at the details of the ill-defined cause of death in the Maldives using 11 years of data, and which goes beyond national averages and looking into the geographic distribution. And the key finding is 1/3 of the deaths are assigned an ill-defined cause of death with minimal improvement over time. And the main reason could perhaps be due to the high turnover of doctors in the country. We do rely on a lot of expatriate doctors who have varying level of familiarity with ICD coding certificate standards, could be contribute to inconsistency in cause of death reporting in the country. We showed consistent in difference by sex with women having higher proportion of ill-defined cause of death across the years, and this reflects sort of the differences in access to diagnostic services that we have across the country, and the distribution of the medical workforce across the country as well. And one of the key findings coming out from this is that WHO recommends that ill-defined cause of death should not exceed 10% for individuals aged 65 years and older, and it should be less than 5% for younger age groups. While we saw from this study is Maldives exceeded this threshold across all age groups, and this sort of indicated there is a critical gap in the mortality surveillance in the country. Just moving on to the last two slides. So what the recommendations that coming out from this, or the next steps that we would like to propose, is that to address this issue in the country, we require a multi-pronged approach that includes strengthening the practice of medical certification of death, enhancing training for the professionals, and implementing a quality assurance mechanism, which is not in place at the moment in the country. Of course, the use of WHO online medical certification of cause of death training might improve the standard certification process across the country and reduce the diagnostic ambiguity also. And being an island nation, developing region-specific intervention will help us along the way to improve the disparities that we have noticed in the cause of death coding as well. So my last slide, given that Maldives is a small island nation and with a dispersed population, improving the cause of death data at regional level is especially important for us, and which could be of relevance for other small island developing states, countries as well. And geographic disaggregation will help us in the future for precise planning and to ensure health system across the country as we prepare to face an aging population. Of course, this research has been conducted with very minimal information. There is a need to do further research in this area in the country, research into the impact of interventions and integrating clinical records, like some of the other researchers have done for birth and death registration, and certifier level variables could be integrated into further analysis to provide deeper insights into the coding practices in the country and help us minimize the ill-defined cause of death in our coding practices. So thank you.
Yes, perfect. Okay, so thank you very much, all the three speakers, for excellent presentations. So we have around half an hour, so I will now move on to the Q&As and panel discussions. Open the floor to everyone. Petra, please.
Yeah, thanks. Thanks, Tum. So this is actually came to mind because of Riaz's presentation, but any of the other panelists could also answer it. So in your findings, you showed very clearly that gender was a key factor and also some other characteristics, but for me, gender kind of really stuck out. But then when you had your recommendations, they seem to be speaking quite generally to how to strengthen the reporting and health system overall. But you've seen that even though Maldives is doing quite well, there are still some specific populations which are not the same as the average, which are being left behind. Do you have any maybe ideas or policies or recommendations which could be targeted to really focus in on the population groups who are most disadvantaged when it comes to cause of death reporting?
Thank you. At the moment, in this research, the most of the recommendations are very much specific to improving the quality of cause of death reporting in the country, especially because we have as I highlighted, we are unable to retain the medical workforce that we have in the country. So the first thing we need to do is how we can improve, even with this turnover of this medical workforce, how we can improve their quality of cause of death reporting, and then to establish a mechanism where we can sort of do a quality assessment of the coding, because with these mechanisms in place, what we feel like is over time, we might be able to see an improvement in the cause of death, ill-defined cause of death given to women, given to a certain pocket of the population. And one of the interesting findings coming out from this is why the youth age population, which is 18 to 35 in the country, is getting a higher odd ratio of being assigned an ill-defined cause of death. And it's something which needs further investigation, further looking into, if we really want to come up with a specific recommendation or policy interventions for this to address this high ill-defined cause of death among this population as well. Thank you.
Questions? I would like to invite other two panel. Do you have any comments on that, please?
Okay, thank you for the question. I would want to respond to it, particularly with regards to the gender differences in the cause of death, and why in our recommendation, we actually haven't specified it, but just thinking through a recommendation, particularly in the case for what I did mention that struck my attention, where I did see that for females, for instance, the last cause of death for female, which was HIV, and then we didn't see that in the case of males, particularly could be more because women are the ones who often would engage these health institutions. So women are usually the ones that go to health facilities to seek medical care and all of that. So it's possible that, I mean, I'm just making a speculation. It's possible that the case of men could be missing, given that they don't often engage with these health facilities more in our context. But yes, it's a good thing to think through. So I would definitely consider including something on gender to ensure that since the results is already presenting that sort of differences, there is a need for it to be included in the recommendation. So thank you.
Yeah, okay, a quick one. I think all these methods have a very good potential, but when you go to further disaggregation, we have to be very mindful of the numbers. I was looking at Maldives, for example. I think when you start giving categories which have more than 3 categories, it becomes a bit difficult. But if you are looking at South Africa, where that is over 100,000, that will be fine. Also, uh, whether in the death certificate we can actually classify the socio-economic characteristics, whatever characteristics we can actually, uh, get out of what's on the death certificate, that can be analyzed, especially for large populations where you have adequate sample sizes. So as we recommend in this paper, one of the things to do is the age, all the age categorization, then the sex. Then I also think even geographic coverage. I think in South Africa we have 11 major provinces. That will be adequate enough. Thank you.
Thank you. Are there any? Yes, please.
Afternoon, thank you. Thanks for the studies. Think Maldives. I wonder if you had considered the experience of your couriers, of your certifiers, because one of the things I think you keep mentioning is the turnover, that they tend to leave. Can that have an impact on the quality of certification, whether or not there can be an intervention also that you regularize the training? I think interesting when we looked at our data in South Africa, we found that older ages are more likely to be coded to ill-defined. And I sort of attributed that to that most of them are likely to die at home. So the quality of certification might be a problem. I also wanted to find out if what proportion of these you ill-defined were actually from deaths that occurred at home. Thanks.
Thank you. As I mentioned, that is the next phase of the research actually to look into these certifiers and their background and where they are coming from as well and how long they have been in the country as well. But just to cite a simple example, the Ministry of Health did conduct a nationwide training for the doctors on cause of death certification in 2019. And if we look at the results, what we see is in 2020, we see the number has increased slightly. In the number of ill-defined causes has decreased slightly. And that may be a result of the training, that the nationwide training that has been conducted, but the challenge there is the Ministry of Health is unable to conduct this training on a regular basis for the newcomers, the new doctors also who comes also. Ministry of Health is unable to conduct this training on a regular basis for them. Yeah.
I saw hands earlier from the back of the room. Any questions? Shen, please.
Thanks. The question goes to South Africa study, William. So I'm wondering, now in the study, around 10% of the EU-defined cause of death was selected as a sample size. So whether there's a clear guidance, whether 10% is a good number to go, or there's some calculation behind. Thanks.
Okay, thank you. I don't know whether Zanile is on the on the line, but I skipped it for that particular reason.
Okay, she's online.
She's
let's
online because I think in the analysis she reverts to the actual numbers. So that's why I didn't mention that part. Okay, but let's clarify from Zanele.
Okay, so Sonali,
The 50,000 versus the 114.
Did you hear the questions?
10% sum.
Yeah, well, it's around 10%, and I imagine reclassification, going back to investigate and reclassify the code or the diagnosis may be resource consuming. So just want to understand whether this number is like the rule of thumb. Thank you.
Okay. She's online. Can you hear us?
Good morning. Good afternoon, colleagues. Yes, I can hear the question. My apologies. I'm not feeling well, but is it possible if you can just the email maybe can be dropped on the chat, the email address for the participant, and I will try to respond.
Okay.
My apologies, colleagues.
Okay, all right. Sorry to hear that. Yeah. Yeah, we can. Okay. Are there any other questions? Thank you, please.
Hi, Claire Connery Murray from the Gender Equity Unit. And I wanted to follow up on Petra's question about gender and ask you to speculate a little bit about whether there's a possibility that some of the gender differences might be due to stigma, that that perhaps families might pressure doctors to not indicate certain causes of death, and whether that might differ, knowing your cultural context, for men and women. Thank you.
All right. Thank you very much. A very good question indeed. And that's actually the problem in our context. Cultural differences, cultural practices, factors do come to play, particularly when it comes to cause of death. Even the fact that our cause of death data is very low can be associated to such, because for cause of death, in the case of the data I have used, the medical practitioner would have to have certified that the person died from this particular disease before that is being inputted into the system. So in the case where the family is not actually interested in pursuing such, then that particular disease would have been missed out in the data. So it's also possible that when it can play a role with the gender differences. And you were right on the speculation on the fact that stigma does come to play, because in the case of maybe very sensitive diseases, people wouldn't particularly, even after death, wouldn't want it revealed in a way. And sometimes trust in the system does also come to play, because we are talking about people visiting their institutions within the jurisdiction for which they stay, and they feel that in some cases they even do know the medical practitioners involved in the cases. So they are not so confident that such a person can keep this data even as a secret. So yeah. But it will be interesting to maybe go more qualitatively to even find out other relevant issues. So thank you. I think I'll probably look into it further. Thank you.
Actually, there's a very interesting problem there. It's actually a hidden problem, because there's an element of selectivity. We know for a fact that even registration of just the fact of death, the death certificate itself, there's that gender differences. So because of that, then it spills over to the characteristics of the deaths, even if they are picked. So it's something which I call cause of the causes. And at times it's so difficult to pick it up in a study like this. This is where you would want to do a bit of qualitative and, start looking at some of these and say, how do we look at it? How can we explain? Because it's a hidden cause, what you have actually alluded to, which at times numbers cannot really tell us. So something like that would be, for those who are actually working on the topic, to say, go further and look at this issue of selectivity, because if it's already disadvantaging females in terms of their being picked up, what about even being certified? It's even a bigger problem. Over to you.
Thank you. Are there any other questions? If you're still thinking, I'll ask questions. Okay, so my questions go to our beloved Tina. Sorry for that. So very interesting to see, the difference in the percent of the defined over time and across geographic locations. But my question is that there's no improvement. In improving in, quality of cause of death in Malay over time. So Malay, it's, where the tertiary hospital located. The health facility, this and that. Yeah, but I saw some decline in the percent of ill-defined in other regions. Is that any? You look at the difference between two periods, early years and later years, right? But any thoughts on that? What happened in Malay, the capital city? Is there any different?
Just to share some insight into that, when it comes to Malé, the capital city, we have more of local doctors in Malé area, but whereas in other rest of the country, it's more of the expatriate or the foreign doctors who are residing in these locations and certifying the deaths. So when it comes to Malé, that's we were also wondering what could be the reason why Malé being the capital and where most of the doctors who are trained and specialized are there attending in the ER and in the medical wards, and we still don't see much of an improvement. That's something again that needs to be studied further as well for in our case. Yeah.
Yeah, thank you, presenters. Presented a very wonderful presentations. I have a simple question for Basir. Basir, there's something which I think didn't capture well what is happening in most of our countries. I know in Maldives they are doing well because the doctors have been trained, and I think they have a better coverage. What is missing? I saw the sample size of around 30,000. And I know in Ghana, maybe in a year, you may be losing over 150,000 days. There is a problem of not coding, which is not, you didn't go to that extent. Much as you did analyze and you did indicate the garbage codes. What is causing those garbage codes? We have a problem. At one time, we even thought about having the ICD coders. Do they have the technical capacity to really record? For us in Uganda, we are even thinking about changing the law. Instead of saying cause of death, say man of death, so that we can capture as many as possible. We have even gone to the extent, because most of the deaths actually happen in the community. We are even thinking about the verbal autopsy. So the research is very good, but I want to see how you are linking to the efficiency indicators. Thank you.
Okay. Thank you very much for that. And yes, indeed, issues relating to mortality is always complex. And even in service, yeah, they are equally complex, because you are visiting the household and you're asking the household about someone that they love that left perhaps a year ago or some months ago. And in our context, people often don't want to even be remembered, like to remember such instances. So sometimes it does even bring tears to the eyes of respondents and can distort even the progress of this data collection. So very sensitive, very complex, and actually very dicey. So particularly with regards to the issues that you indicated on the what could be accounting for the low records in terms of the cost of death, aside the fact that I had earlier mentioned culture, also, let's bear in mind that to perform to get a pathologist to perform that autopsy test on the disease, that's come with a cost.
Mr. Kasum, one thing I don't even go there. Because you are going to start seeing the men of death fell down and died. Because you are allowing anything for them to write anything. I would rather think, let's stick to try to, I don't know, the capacity building of certifiers and whatever. But the moment you relax the definition, the more useless the data becomes. That's where the problem with that category, of, cause of death or is, because if you relax, you just get data which is not useful for public policy. I know you want to make life easier for NIRA, but I think relaxing that, don't even go in that direction. Yeah. Okay.
So one last question. So to all the panelists, if you had one message to share. Oh, okay. Yeah, please. Go ahead before I'm wrapping up.
Thank you. Nice presentations. And this one goes to Maldives. I think anybody in the front, in the panel can answer. You were talking about the region, Mali region, where you have you classify them as well-trained doctors. They might be well-trained in the area of medicine, but not in certifying the course, which means we need to revisit the curriculum, include the certification in the curriculum of doctors, so that it starts from the well-training, which includes certifying. I think that could help a lot. Thank you.
Yeah, definitely it would help to improve it. But the thing, just would like to highlight that currently in Maldives, we do not have any medical training or any of the MBBS courses being conducted in the country. So all the doctors who are working in our medical health workforce are trained abroad, be it locals or the doctors that are coming to work in the country. So that's the reason why we have emphasized in our analysis that it's important that we conduct a regular course of death certificate and training in the country, or doctors do follow the MCC or the WHO training online e-learning module that is there as well. So we need to find a way somehow that there is an ongoing training for the doctors to improve their course of death training in the country. Thank you.
Yeah, in addition to that, I think one of the things which have become very evident is, the training which we provided to doctors who are already working, it was a waste of money. Because you are training people who are not even keen to use it, or because they think their work is more on, the medical field. So One of our recommendations is catch them when they are still at university and make it part of their working life. You will be required to do this when you get to hospital, just like how they do their housemanship, you know. So we were targeting the wrong people, the wrong doctors. So the doctors which we should actually be looking at are those coming into the system and say, these are the requirements for a well-qualified doctor you are supposed to. If a person dies in your hands, these are the things you are supposed to do. So it's the curriculum which needs to change at medical schools. Otherwise, we'll keep on training these doctors at such high cost, but we'll never. Actually, you can see South Africa, it's increasing, right? But the number of doctors are also increasing and whatever. So it's like you are almost blowing the problem, you know, out of proportion because of that. So I think one of the recommendations for this is really, let's look at where training is actually required. It might take us 5, 6 years, but the moment now they start going into practice and they make it their working requirement, routine, and so forth, then we start harvesting those benefits. Thank you.
Williams. So now I think it's time. Yeah. So I'd like to thank our speakers for sharing their valuable experiences and insights, and all participants for your thoughtful questions. So please join me in giving a round of applause to our speaker and to yourself as well. So as we close, I hope this session reminds us that improving cost of that data, it's not only the technical exercise, but it's a critical step towards, making people and their health outcome visible in our system, in statistics and in policy. Thank you everyone for joining us and for your attentions to the session. Thank you. And thank you, my co-moderator.